Go on to our next speaker, Dr. SATHI Devi, who's a consultant glaucoma services at Narayan Netralaya, Bangalore, with a long experience. And she's going to talk on a very interesting topic, shallow anterior chamber post-trabeculectomy. On to you, Dr. SATHI.
Yeah, a very good evening. So I'll be talking today about shallow anterior chamber post-trabeculectomy. With glaucoma surgery, we are always looking at doing the balancing act between overfiltration and underfiltration. Shallow anterior chamber is one of the most common complications that we encounter in the postoperative period, and this can be associated either with a low intraocular pressure or with a high intraocular pressure. The two most common scenarios that we often see are wound leak and the overfiltration. High intraocular pressure is a little uncommon. I'll try to cover two case examples of this scenario. So this was a 64-year-old patient who had primary angle closure glaucoma and underwent a fornix-based trabeculectomy with mitomycin C. And on the 5th postoperative day, the patient presented with this shallow anterior chamber. So both in the periphery as well as centrally, you can see that there's a shallow chamber. The intraocular pressure was 2 millimeters of mercury. And on examination of the bleb at the slit lamp, the bleb was found to be relatively flat. And you can see that there is a leak that is happening at the edge of the conjunctiva. Patient was also noted to have peripheral choroidals. Now, how could we prevent this? We would need to, during the surgery, avoid the mitomycin coming in contact with the edges of the conjunctival flap. Gentle handling of the conjunctiva intraoperatively to avoid buttonholes is very important. At the end of surgery, it's important to ensure watertight closure on the table itself. So this is truly a situation where a stitch in time saves 9. So if you do notice a leak on table, it's better to take care of it there. So here in the first figure, you can see that this is a limbus-based flap. And in this situation, you can do 2-layer suturing, the tenons and conjunctiva. So it gives a really watertight closure. And generally, the leaks in this situation is extremely low. This here, the third picture here shows a fornix-based flap. And so you're suturing at the limbus. I'm using a frill of conjunctiva and closing it conjunctiva to conjunctiva. Again, with careful suturing, you can get a watertight closure. Now that we already have a leak, what do we do next? A bandage contact lens is extremely useful in this situation. It covers the area of the leak and facilitates epithelial migration. So here you can just see the lens being inserted. The edge of the lens seen here should well cover the area of the leak. So if you have the edge rubbing against the leak, then that could prevent closure of the leak. So that one needs to be careful about. You reduce topical steroids so that there is some amount of inflammation and you want the leak to heal. You can give cycloplegics, which will help in posterior movement of the lens and formation of the chamber. And you can also give drops like gentamicin, which cause some amount of conjunctival inflammation and stimulate wound healing. Oral doxycycline is also useful. Now, by day 17, with all these measures, the leak had sealed, the anterior chamber had formed, and the intraocular pressure had come back to 12 millimeters of mercury. Now, when would a surgical intervention be required in such a situation? Usually very uncommon. Most of these respond to conservative management. But if you see that there's an imminent risk of bleb failure, if the bleb is getting scarred, you see a brisk leak which is persistent, and this places the eye at high risk of infection, then you would want to go in and close the leak. Also, if the shallow chamber persists for very long, there is a risk of peripheral anterior chamber, PAS, peripheral anterior synechia formation. And sometimes if the shallow chamber remains for long, even though not at that time, later when the patient undergoes a cataract surgery, the cornea could decompensate, hypotonous maculopathy can happen, persistent ocular pain, all this would be indications for surgical intervention. Emergency situation that you would need to intervene is if you see kissing choroidals or a lens cornea touch. This is a second case, which is a 72-year-old male, primary open angle glaucoma who underwent trabeculectomy. Again, on day 5, you see that the chamber was shallow, pressures were 3, and he had peripheral choroidals. However, this case differed in the fact that there was a very large bleb and there was no leak that was seen. Now, this differentiation is very critical because the management is totally different. So here, to prevent this, you on the table, make sure that the AC is formed well intraoperatively, adequate thickness of the flap, the covering of the stoma by the flap. So central 1/3 alone, you have the stoma. Use adequate scleral flap sutures, use releasables, avoid flap tears or disinsertion. Check the filtration after your suturing, instill a cycloplegic at the end of surgery. Management, you can give a pressure bandage. Usually I give it during the waking hours to avoid during Bell's phenomena. You don't want the pressure bandage on the cornea. Increase topical steroids, put atropine. And with this, the patient by 8th postoperative day, AC was much better. And by 14th day, it was well formed. Pressures were 10 and choroidals were regressing. Again, these also majority settle down with conservative management. Very few require surgery. If the chamber does not follow, then a wound revision with resuturing of the flap may be required. If the flap is badly damaged, then you may have to consider a scleral patch.
Ma'am, 1 minute remaining.
The situation of high intraocular pressure in shallow chamber is, like I said, quite rare. Pupillary block, which can happen either due to imperforate PI, block by blood, fibrin or vitreous. You need to relieve the block. Malignant glaucoma, again rare, more common in angle closure eyes. Medical management, laser hyalodotomy or iridozonular hyalodotomy may be required. Suprachoroidal hemorrhage is a devastating complication. It may still be possible to salvage with appropriate intervention. It's quite common in myopic eyes, aphakic, post-vitrectomized eyes. In this, you would need to use an AC maintainer, avoid sudden decompression or hypotony. So I would like to conclude by saying that postoperative complications are fairly common post-trabeculectomy. They're mostly transient and respond quite well to conservative management. Recognition of the condition, assessing the etiology, and appropriate management help in preserving vision and bleb function. Thank you.
Thank you very much for throwing light, so much light on a very important aspect of our trabeculectomy surgery. I would have a question for Dr. Vijaya. How would you actually differentiate overfiltration from aqueous hyposecretion?
Overfiltration with the aqueous hyposecretion. Overfiltration, usually we notice in the immediate postoperative period, mainly because of the closure is inadequate. And when there is overfiltration, there will not be any leak from the edge, and there will be very large bleb functioning and associated with the hypotony and hypotony related sequelae. When there is aqueous suppression, there is no production of the aqueous. I don't expect a well-formed bleb in such a situation.
Or could bleb will not be well formed, and maybe if there is some inflammation.
You have to rule out a possible leak. So doing the sedals, even if there is a leak, you will not have a well-formed bleb.
Yeah. Or if there's some cyclitis or inflammation, probably too, you could have.
Unlikely you see that often such a problem in the immediate post-trabeculectomy. So those conditions you see in the long run rather than in the immediate post-operative period.
Many times we have seen, ma'am, like when you talk about sedals, during the normal sedals, there won't be any leak. But in some cases where the pressure sedals, slightly there will be a leak. Many times we won't find it. And we constantly have this bleb being flat. But one normal sedals, it will be negative. But once you have a gentle pressure sedals, it will be positive. So many times we see that situation also. I don't know how many of you have faced that.
I think of force.
Sorry, go ahead, Sathya.
Pressure sedals, just gentle pressure, you can see that there is a leak.
Yeah, so force sedals can be seen often, but that is even easier for it to settle with the same conservative management, because most of the time without the pressure, there is actually no very active leak.
Yes. I don't know who interrupted this. How would you manage conjunctival leaks, the intraoperatively in fornix space incisions, Dr. Tanuj?
I think that is the most critical question you have asked. And I have also had several leaks and still I'm refining my closure. So the first thing I do is now on the table when the surgery is ending. So I have closed the fornix base flap. So I ask my assistant to pour trypan blue on the site of closure and I inject balanced salt solution from the side port. So when the second option is that when you have done the surgery, you are giving the subconjunctival injection that will balloon the conjunctiva. At the same time, you can put trypan blue. So if there's any area where there is leakage, you will see that trypan blue getting diluted. So I think that is an acid test that before closure, you balloon the conjunctiva with either of these two maneuvers and check for leakage on the table. If you find an area where there is dilution of the trypan blue, you immediately suture it on the table. Second principle is don't rely on absorbable sutures, Vicryl. So I have burnt my hands. Vicryl, you are never sure of the integrity. So the apposition of the conjunctiva to the cornea, you may use 1 or 2 Vicryl sutures to hitch the conjunctiva, but the central closure must be done with a watertight 10 monofilament nylon suture. That is a must. And third modification recently I have started doing is because you can get a lot of astigmatism when you apply 10 suturing to the periphery of the cornea. So I leave a frill of conjunctiva, and then we are just trying for the last maybe 3 months to use 10O Vicryl. So that's a very fine suture, and the space between 2 bites is very minimum. So we go 2 ways, and that has given in the initial study we are doing good results, but I'll wait and maybe 6 months later I'll tell you that. So these are 3 different techniques you can use. And if you find post-operative there is a micro leak, then of course you can manage it. But if there is a gap between 2 sutures in a fornix based flap, then better to take the patient to the OR and suture it, because you are exposing the patient to a risk of phlebitis, and then it becomes a very difficult situation. So micro leaks you can manage conservatively, but if there's macro leak between 2 suture lines, then you should seal it in the operation theater. Thank you.
And of course, very atraumatic handling of the conjunctiva, and I suppose including tenons in your suture.
Yes.
Should be it. So any other question from the expert panel on this talk before
comment on this? Actually, you should also aim for a posterior flow of aqueous, because if the aqueous flows posteriorly, then the approximation of the conjunctiva to the limbus is better. And Dr. Tanuj has suggested not to use Vicryl, but I have been using Vicryl for so many years, and I now give purse string sutures on the sides. And the advantage of having purse string sutures is that the tension of the suture is at the limbus. So the chances of retraction of the conjunctival flap is also minimal. And in the center, 2 bleb forming sutures, it can be given either with nylon or with 10O Vicryl. So yeah, the aim is to have a very good watertight closure of the conjunctival wound, and aim for a posterior egress of the aqueous rather than having the egress of aqueous from the sides, which can prevent healing of the conjunctival flap.
Thank you. Thanks a lot for